Hi there. Welcome to this evening's webinar, which is brought to you by Fertility Network UK. And joining us this evening is our guest speaker, Dr. Matthew Pryor. So Dr. Pryor will discuss the role of progesterone in preventing miscarriage. And Dr. Pryor is a consultant gynecologist in reproductive medicine at Newcastle Fertility Centre. So as I said, this webinar is brought to you by Fertility Network UK. I'll just actually share my contact details on the screen. So my name's Sarah. I'm the Scotland branch coordinator for Fertility Network UK, and I actually manage the pregnancy loss group. So if you would like to join our pregnancy loss group, please get in touch with me after this webinar. We've got a pregnancy loss group for those who have experienced loss after trying to conceive for a really long time and or following fertility treatment. And these groups are for those who are trying to conceive for the first time and also those who are experiencing secondary loss. So please do get in touch. We have a closed Facebook group as well as a WhatsApp group. Also, if you can donate tonight, that would be great. We do suggest a donation of £3. We'd be absolutely over the moon if you could do that. You can donate now via text or via our Just Giving page using the hashtag help us to help others. So I'll just pass you over to Matthew, who will start his talk, and then afterwards we shall go through the questions that were submitted. So thanks so much to everyone who submitted questions for the webinar this evening. That's been really, really good, really helpful. We've quite a few questions to get through, so I'll just pass you over now.
Hello, good evening. Thank you very much for inviting me, Sarah and Fertility Network UK. This is a topic that's like really quite important to me and close to me because I did a lot of research around this area throughout my training. Let me see if I can share my slides with you. There we go. So I've got a few slides to go through, just to sort of give a rough sort of background to the role of progesterone in preventing miscarriage, and to look at a few different things and go through lots of your questions. So who am I? So my name's Matt. I'm a consultant in reproductive medicine at Newcastle Fertility Centre. So we're up in the north of England, and it's a large NHS unit, and we see patients right through from their initial GP referral all the way through to complex IVF treatments. Many of our couples or patients get pregnant naturally, and we also run a recurrent miscarriage service for women who have recurrent miscarriage. I did a PhD at the University of Nottingham looking at uterine anomalies and miscarriage, and did quite a lot of work reviewing sort of the impact of progesterone in treating all sorts of pregnancy problems. I was on the RCOG, the Royal College of Obstetricians and Gynecologists Council, which is their big body, for 3 years between 2014 and 2017. And I've got an academic interest in miscarriage, but probably more recently in my current job. I enjoy seeing patients and talking through the difficult conversations and managing the difficulties around pregnancy loss and miscarriage. So I've got two acknowledgements. Normally you put these at the end, but I think it's quite important to mention them up front. These are two people who are quite big names when it comes to research in reproductive health. And the first is Professor Ari Kumarasamy, who's a professor in Birmingham. And it was his team that did two of the largest studies in relation to miscarriage. And he's a good friend and colleague of mine. And I've worked very close with him with my research and his ongoing research studies. The second is Professor Jim Thornton, who is an obstetrician in Nottingham. I think he's just recently retired. but he's a trialist and really looks at in detail at how research is conducted and has a very high threshold for saying something is okay. So that this will add a bit of credibility to a lot of the research that we're going to discuss this evening around progesterone. So background, I've done some research and I've set priorities for research in miscarriage and led a big group in 2017, 2018, including Tommy's, who fund the National Centre for Miscarriage, looking at what patients and professionals' research priorities were for miscarriage. I've looked at different studies in terms of progesterone and pregnancy and looking at how perhaps some of the research wasn't conducted to a very high standard previously. And then probably this last paper, which I was involved with, Ari Kumasamy, really was looking at the title of this talk tonight, so Progesterone to Prevent Miscarriage, where we looked at all the evidence. And that was really the driver behind changing the UK NICE guidance. And these are the papers that we've been involved in. So the things I'm going to talk about this evening, and I'm not going to take too long because there's been loads of questions submitted, and I think it's really important to try and get through as many of those as possible, because I mean they're your questions at the end of the day, which are a lot more important, but some of them will get covered in the body of the talk. So let's talk a bit about miscarriage, progesterone treatment, like why, what's the sort of rationale behind it, the two definitive trials that really help make us plan for what we can do to prevent miscarriage and how that's implemented the UK NICE guidance. And you might find that different units have implemented it slightly differently and people get a bit of a varied kind of subtleties between different areas. And some of the questions follow that, and we can go through that later on. So first of all, I don't need to tell anybody in this group about miscarriage, but 1 in 4 women will have a miscarriage, and obviously the impact can be physical, and it's an unpleasant experience to go through. But often speaking to patients and listening to what they say, actually the emotional impact of a miscarriage can sometimes be far stronger and greater than the actual physical signs of miscarriage. And it's really important to remember that. Julia Bueno is a psychologist who experienced pregnancy loss and has written a book called The Brink of Being. And I think this quote's really powerful, that the grief of miscarriage can last forever. And sometimes I think as clinicians, and I'm not making any excuses for it, but we sometimes think and have consultations after pregnancy loss and be like, okay, so you're ready to try again or to move on to your next cycle of treatment. And I think that sometimes ignores the fact that really, like, that miscarriage is always going to be part of you, that pregnancy loss, that baby, however you want to view it, is always part of your life, and it's something that you will have experienced forever. And it's important to think that it's not just the experience at the time, but the long-lasting impact that can have. And so preventing miscarriage is really important. But the most common question that patients ask, and this is what came out of the survey I did looking for research priorities for miscarriage, was why did it happen? Like, what did I do something wrong? What was the cause for the pregnancy loss? And unfortunately, most of the time, we can't provide a good answer. It tends to be that studies look more at women who've had recurrent miscarriage, and that depends on which country you're in or which organisation or guideline you follow as to how you define that. Sometimes in Europe, they say after 2 pregnancy losses. In the UK, it used to be 3 consecutive pregnancy losses, but it depends on what you look at as to how it's defined. But looking at causes of recurrent miscarriage, this is a really good study that looked at what the different causes were, and like over half of pregnancy losses are due to chromosomal problems. So that's where the egg and sperm meet. They should have half of the chromosomes each, so there should be 23 pairs altogether. And quite often, either because of a problem with the egg being a bit older, but could be a sperm issue, or it could even just be a replication when the cells start to divide. A copy and paste error occurs and you end up with an extra chromosome or one missing. Now, the most common the most common condition we know with extra chromosomes is an extra chromosome number 21, which causes Down syndrome. But many of the other chromosomes, you can either have an extra one or one missing, and they're not compatible with a particular syndrome, or not really compatible with having a viable pregnancy and a healthy baby. And that's often the cause for miscarriages. And in recurrent miscarriage, we think it's probably over half of those, maybe even more, when you look at initial pregnancy losses, if it's your first pregnancy loss. There's some other random causes, like quite rare, some called antiphospholipid syndrome, where the blood gets sticky, mixed causes, where there's various different things, uterine anomalies, where funny shaped womb or fibroids, and then some endocrine disorders where it might have a thyroid dysfunction or diabetes, or even perhaps obesity might be linked with miscarriage as well. So there's some sort of rarer causes, and they're all sort of much lower than 10%, even in women who are having recurrent miscarriage. But then there's this group that we just don't know what causes it. Probably about 1 in 4 women never have an explanation as to why they've had a miscarriage. And it's this group that we're really interested in, because the other groups, progesterone isn't going to be an issue because there's another explanation. But perhaps the unexplained groups of 1 in 4 pregnancy losses, there may be in there a group of women that perhaps have a progesterone problem, and it might not be in every pregnancy, it might just be in a specific pregnancy, and they're the ones that maybe can benefit from progesterone. So I think this is a really important slide in right up front in terms of saying that progesterone is not going to help everybody. It's only a certain group of women, and unfortunately at the moment there aren't any good tests, there aren't reliable levels that we're aware of, that we know it can be shown to show that you've got a progesterone issue. So that makes treatment difficult sometimes. So what about progesterone? What is it? Well, the clue's a little bit in the name, progesterone. And so that means comes from Latin. So pro, in favor of, gestare, so that's the period between conception and birth, like gestation, and then orone, as in hormone. So it means like a pro-pregnancy hormone. So for a long time, clinicians and researchers have thought, well, actually, the clue's in the name. This is a hormone that's vital for pregnancy. Perhaps this might help. But where does progesterone come from? And so we need to go a little bit back to basics and think about how the menstrual cycle works. So there's 2 phases to a woman's menstrual cycle. The first phase, so from when the period starts all the way through to ovulation, is called the follicular phase. And what happens is in that phase, like tiny little follicles, the ones that we often see on an ultrasound scan in fertility clinics, will get bigger. And normally one of those gets bigger, but if you're having IVF, for example, you have medicines to make more of them get bigger and to develop and mature eggs. Once that egg's released, ovulation, the follicle then is called something called a corpus luteum, and you move into this second half of the cycle called the luteal phase, which is denoted by yellow here. And that corpus luteum produces progesterone. Now, you might be familiar with this little graph here back from GCSE science. There's 2 hormones that the ovary produces, so estrogen, so that's mainly predominantly in the first half, the follicular phase of the cycle, and that causes the lining of the womb to thicken up, ready to implant an embryo if pregnancy occurs. But progesterone levels always stay low at the beginning of a cycle. The only thing that produces progesterone is the corpus luteum, or the placenta. And so it's only important to check levels later on in the cycle. And because it goes up and down, and women aren't quite like textbooks either, you have this lovely chart here, but this doesn't replicate what happens in every woman's menstrual cycle. It's just an average. And if you check it on a different day, you might get a lower level or a higher level. And so therefore, it's very difficult to know what adequate levels should be. But progesterone's there, it maintains the lining of the womb, it maintains a pregnancy. And if implantation doesn't occur, the levels fall and you have a period and the cycle happens again. If pregnancy does occur, the corpus luteum doesn't die away like it shows in this picture. It continues to produce progesterone to support the pregnancy. And we know that progesterone is essential for pregnancy because if you do an operation and remove the corpus luteum early on in pregnancy, or if you use anti-progestogens, so they're medications that block progesterone, that ends pregnancy. And they're what are used for termination of pregnancy in terms of medical termination, something called mifepristone. And the other thing is induction of labor. If you give that later on in pregnancy, that induces labor. So we know that progesterone is essential for pregnancy, but no one's ever described a human deficiency state. You do get some hormones that just can't be produced due to like metabolic pathways and different enzymes and things, but no one's ever described that in humans. So we don't quite know what a deficiency state actually looks like. Now, I'm just going to take a bit of a detour now for a second and look at a case study. So this is a young, and we often see this because in medicine and talking to friends about what happened. So she's had 6 miscarriages before, and the doctor says, "Oh, look, you really had a rough time of it. Let's try progesterone next time. I don't know if it's going to work, but let's try using it." And she takes progesterone and has a baby. The next pregnancy, she didn't really like using it last time round, didn't take progesterone, and unfortunately has another pregnancy loss. And then in a final pregnancy, she is pregnant again, this time definitely going to take progesterone supplementation and has a baby. So if this is your friend or someone that you hear or a story, you look back at it and go, well, obviously it was the progesterone. It's only logical. This is the only time she's ever had a baby has been due to progesterone. But this isn't a great way of conducting science, because you'll also find women who've had 6 cycles of IVF, had an embryo transfer and had McDonald's chips on the way home, and then had a baby and then didn't have the chips and didn't get pregnant. Now, that doesn't mean that it's the McDonald's chips that caused it to happen. And we all know that that's a sensible thing. So it's the same kind of approach that we need to take when looking a bit more scientifically at the evidence. And that's because when we look at different levels of evidence, expert opinions are just what your doctor thinks is actually not a great level of evidence. It's a bit better if you've got a case report like the one we just had, or a series where actually we gave it to 10 women and it improved their pregnancy rates. But the best quality evidence is something that comes from randomized controlled trials, where women are either given the intervention, so in our case, progesterone, or a placebo, and they don't know, and the researchers don't know the difference. And having randomized controlled trials is really important in getting evidence, not only to show there's definitely a benefit, but also to see that there's no harm from any intervention. The only thing that's maybe a bit stronger than a single randomized controlled trial is if you put lots of them together, and that's because you have more patients involved. But actually, the best trial is one that's well designed and large enough to be able to answer a clinical question. So the highest levels of evidence are reviewed in meta-analyses of randomized controlled trials, and the Cochrane group does that. It's an international network, and they have very rigorous when looking at the evidence to make recommendations. And there's 2 that have been published looking at progestogens to prevent miscarriage. So the first one is looking at progestogens versus placebo to prevent recurrent pregnancy for women that have recurrent pregnancy loss. So after having 3 miscarriages, if you given progestogen versus placebo. It's interesting, like we're talking about progestogen and progesterone, and perhaps I'll come to this a little bit later, and that's a little bit different to do with progestogens are synthetic and they're not quite the same as what the body produces, whereas progesterone is the actual hormone that's identical to what's produced by the corpus luteum. Now, what you can see from this study here is, from this chart here, it's something called a forest plot. And the very first study at the top by Swire was published in 1953. And then so you can see a lot of these studies were all published like quite a long time ago in the 60s, and are not all that, only had very small number of patients. The patients will have known what they were taking. And when you look at the graph down the side, there's a line down the middle, and any of the studies that cross that line in the middle, it shows they're not statistically significant. It means that it's as likely that progesterone or placebo is going to be effective. But by putting them all together, and what you can see is this study down here, Kumasamy 2015, which we'll come to in a minute, which makes up 28% of all of the studies, is really narrow and just about sits on this line. And you put them all together and it just by a whisker favours progesterone treatment in reducing pregnancy loss. And this is using progesterone in women that have had recurrent pregnancy loss. There's only 2 studies looking at progesterone as a rescue treatment. So that's using it for a different way for threatened miscarriage. So that's when women have bleeding in early pregnancy, and the trials that were done gave vaginal progesterone versus placebo, and the outcome that they looked at was the chance of having a baby. And again, when you put the 2 studies together, like a massive one, 98% is made up by something called the PRISM trial by Kumasamy in 2019, which we're going to come to in a minute. And a little bit from this older study in 1987 shows just about, again, only just favours vaginal progesterone. And it's based on these 2 studies, when you look at everything together, that sort of helps decision makers when writing guidance. But I think it's really important to look at these 2 trials in a little bit more detail, because these are the best trials. They were designed very well. There was a lot of money spent on them. They were done across multiple sites in the UK. So it's more reliable and transferable to women rather than just like a single centre study. And so the PROMISE trial, so this was progesterone given to women who'd had at least 3 miscarriages before, and they gave progesterone or placebo right from a positive pregnancy test. And you can see that from here, overall, all participants at the bottom, where you've got this red diamond, it crosses the line and overall didn't show any benefit at all. But interestingly, if you look along here at the analysis, if you've had a previous miscarriage, like 3, 4 or 5 or even over 6 miscarriages, it starts to look like it's more effective, as in the little square in the middle goes further over towards favouring progesterone. So that's just something that the researchers found interesting, but this study only had 800 patients in it, and it was hard to draw any conclusions. The PRISM trial looked at progesterone for women with early pregnancy bleeding, and you didn't have to have had a miscarriage before to be enrolled in this study. And this had over 4,000 women in it. About half had progesterone, half had placebo. And again, you can see overall, it just about hits the line, and kind of the headline figure is it doesn't make any difference. But when you look through, you get this gradient. So this is a completely different study, different number of women were in the study, but you see this same effect, that the greater the number of miscarriages, the more likely progesterone is to be effective, and that goes all the way across. So that's an interesting fact, and the researchers sort of scratched their head like, well, why would this happen? And that really goes back to our very first chart as like what causes miscarriages. And we said over half of them are caused by chromosomal problems. And it doesn't matter how much progesterone you give, if there's the wrong number of chromosomes that's there right from the very start of the pregnancy, you're never going to be able to correct that with progesterone, with a hormone. And so therefore, that group, you're never going to see a benefit. But this study here demonstrates that as women have more miscarriages, they're more likely to be losing babies with a normal fetal carrier type, so with normal number of chromosomes. So therefore, perhaps when you go through and have more miscarriages, there's more, you change the balance as to what might be causing them, and there may be more women in there that have a progesterone defect, and that's why you see that gradient that we saw in the last chart. So it's a little bit complicated, but there's some science behind it. And it's quite important to realise this, because it helps explain the rationale behind the guidelines. So the overall effect when you put these 2 studies together is that it just about favours progesterone. So this was looked at after about a year by the UK NICE committee. And NICE is an organisation in the UK that make recommendations about the effectiveness and also the cost effectiveness of treatments, not just in women's health, but everything from high blood pressure to having hip and knee replacements, to preeclampsia and pregnancy problems, and also there's a guideline on ectopic pregnancy and miscarriage. And this was updated based on the results of these studies. And the recommendations were that vaginal micronized progesterone, so that's using vaginal pessaries containing natural progesterone, are used at a dose of 400 milligrams twice daily. And that's because that's the dose that was used in the studies. And that was recommended for women who've had history of a previous miscarriage and early pregnancy bleeding. And they made these recommendations because that was the only preparation that was shown to increase the number of live births, and there's no benefit for any other preparation. So they made that recommendation for research. This has now made its way into the British National Formulary, which is almost like the Bible for prescribing. This contains all the medicines that doctors can prescribe in the UK. And now, for example, cyclogest pessaries, which is one of the preparations often used in IVF, also has a license now, is mentioned for treating threatened miscarriage. Now, I've got a little video that will just go through some of the things that we talked about and summarize the whole talk, and then we can get to some of your questions. So thank you very much. That summarised everything we've been through. Just a little plug here. I do run a sort of side project called the Big Fertility Project, which provides patient information and is we're looking for contributors who want to collaborate or share their story on there, and have a small Instagram account also called the Big Fertility Project, which is linked with the website. So if you want to follow me or reach out or share your story to help others, then I'd love to hear from you. Thank you very much.
Thanks so much, Matthew. That was really interesting. It's really helpful. And I think one of the things that I learned definitely from the information you gave was how progesterone, it can only really be used in really kind of very specific circumstances, which was really good to know. So what I'll do now is I'll just share the questions. Sorry.
We had them there for a second.
Yeah.
Yeah, the stories can be shared anonymously on our page. I'm just looking at some of the other questions that have come through.
Okay, so that's the first question there.
Okay, so is there evidence that progesterone can improve the uterine lining thickness to help with implantation? So there's not very good evidence for this at all. Progesterone maintains the lining of the womb. It doesn't thicken it up. That's what estrogen does in the first part of the cycle. So we don't think that it's likely to help with that. This concept of a short luteal phase is a difficult one because no one's really able to define that yet, and it's also quite difficult to know when the luteal phase started. And often I think the reason why you might have a shorter luteal phase in a particular cycle is maybe because the egg that's released wasn't very good quality, and that means that the corpus luteum then doesn't produce as good quality progesterone at all. There's a really interesting study that was authored by trying to remember her name. She's a big Instagram person, Natalie, American woman. The name will come to me in a minute. And she looked at women who had a short luteal phase and looked over like a year, and it showed that over a year's trying, those who thought they had a short luteal phase versus those who didn't had exactly the same pregnancy outcome. So there's never been any studies looking at like progesterone supplementation in the second part of the cycle, but I think all it might do is just potentially mask when not a very good egg's been released, and then you never quite know when to stop the progesterone, which then delays your period and delays the next cycle from happening. So I'd be very reluctant to use progesterone supplementation in those circumstances.
Okay. Was it Natalie Crawford by any chance?
That's it, Crawford, yes.
Yeah. I just did a quick Google there. So question 2.
So are injections better than pessaries? So depends what you mean. If we're in the UK, there tends to only be one injectable progesterone called Lubion, which again is a natural progesterone. But many studies so if you're in America and you're having fertility treatments, you're quite unlucky because you have to have an intramuscular injection, which is really painful and expensive. Whereas in the UK, we tend to use more vaginal pessaries. And there's perhaps some evidence that if you don't absorb enough through the pessaries, the injections might be enough just to top it up. And that's more useful in women having fertility treatment rather than, I mean, it's never been studied in those who have recurrent pregnancy loss. I've had patients ask me, because like taking the pessaries isn't necessarily all that nice, and some people are like, I'd rather have an injection. I'm a little bit cautious about that, because one thing, when you think about taking a medicine, you got to think how it's handled in the body. And one thing that's quite clever about a lot of the pessaries, particularly cyclogest, for example, is it melts at body temperature, which means it's absorbed really slowly over over 12 hours, and it's in the right place, it's in the womb to support the pregnancy. Whereas with injections, you find you have the injection, you get massively high levels in the blood, but then that kind of drops really quickly, and by the time you're on the next injection, there might not be any there at all. So I think it might be helpful as a supplement, but I don't think it would be a good idea to use it as an alternative.
Okay, thank you. Question 3.
This is a really difficult question, because I think like getting between sort of teeth into it perhaps suggests is it better have it going privately than having NHS treatment, and often that might be what's portrayed by some private clinics. Oh, we're going to treat for longer, or give it sooner, or use a different preparation that's more expensive, and often like more expensive, you automatically think in your mind, oh, must be better. But ultimately, like private clinics and NHS clinics, they don't know anything other than what's published in the literature. And the largest studies are the ones that we talked about today, looking at progesterone in terms of pessaries, vaginal progesterone. So honestly, like private clinics don't have some secret source or have some secret research that we don't know about, because even so, like no clinic's big enough to have been able to do a trial looking at this. So really what's recommended by NICE is the best evidence that we have to go on.
And it's often the same people that are treating you as well, isn't it, that you pay for privately?
Exactly, yeah. Often it's the same consultants that would see you privately in the NHS. Sometimes the only thing as a private patient, NHS might be restricted as to what they can prescribe. So if you say, oh, I'd like to have this different preparation, it might not be as straightforward because of what they're allowed to prescribe. But if it's private, you're paying for it. So doctors might have a bit more freedom to prescribe other things, but in terms of the evidence for what works better, there's no difference.
Yeah. Okay. So moving on to question 4.
What level would you look to achieve after an embryo transfer? So this again only applies to IVF and only really applies to frozen embryo transfers, because this is, and the evidence isn't brilliant for this, but it's about the only situation where you can do a progesterone level and it perhaps give you a bit of an idea as to what the outcome is, whether the levels are high enough. And we don't do this in our practice, but I think it's 30 nanomoles that you need to look for in terms of the level to be high enough. And if not, you've got to remember you're already using pessaries, and measuring a level in the blood isn't the same as measuring it in the uterus, which is where it needs to be. So we don't know for certain what levels to look for, but off the top of my head, I think it's 30 nanomoles that we're looking for, which in terms of nanograms, I think that's about 10, or it's the other way around. Can't remember. I think 10 and 30 are what they're equivalent to.
Okay, thank you. Question 5.
So some say it's safe to come off when they're pregnant. If you've had a miscarriage, is that still safe? So you got to think, well, the corpus luteum and progesterone supplementation is there until the placenta's big enough to produce enough for itself. And it depends on how you're having treatment. So if you're having a fresh cycle of IVF treatment with a fresh transfer, you've had loads and loads of follicles producing estrogen. So estrogen levels are like really, really high in a IVF cycle compared to what happens naturally. And we always give progesterone because we always have, thinking, oh, maybe those corpus luteum are damaged because they've had a needle in them. But actually, by the time you get a positive pregnancy test, they're all producing a lot of progesterone, and progesterone levels are quite high in a fresh cycle. So many clinics say it's safe to stop when they're pregnant with a fresh cycle. In a natural cycle, some clinics supplement progesterone, but many don't to keep it truly natural. But in a medicated frozen cycle where you actually suppress the ovary, so that it's not producing any progesterone at all, it makes more sense to continue it for longer. Now, no one quite knows how long. Our clinics stop at 12 weeks. It's probably high. It's probably okay by about 8 weeks. If you look at it in terms of reducing the risk of miscarriage, if you look in the BNF, and the studies, they continued it to 16 weeks, which a lot of people think is slightly overkill. But the reason why that happened was because the last thing you want if you're running a study is to be accused, well, actually you stopped it too early, or you didn't give a high enough dose. So often you go on a little bit further. But I don't think anyone's going to sign up to my randomized control trial of stopping progesterone earlier on to see whether it increases their risk of miscarriage. So I don't think we'll ever have a good answer to that question. But it's most likely like the placenta's reasonably well formed by 8-9 weeks. I would imagine at that point you're probably producing enough. But most clinics will be a little bit play on the safe side and go a little bit longer.
Okay. Question 6.
So when there's a history of miscarriage and then bleeding in pregnancy following a positive pregnancy test, why is it not prescribed until the sac's been seen? Could it cause any harm? So the NICE guidance and the committee that reviewed the guidance, one thing early on in pregnancy, you don't know for certain that the pregnancy is in the right place. It could be an ectopic pregnancy, or it could be a pregnancy of unknown location. And they were concerned that by starting progesterone early, that might mask some of those pregnancies, and therefore recommended to do a scan first that could be seen in the early pregnancy clinic. Now, they say that you could prescribe after you see a sac on the scan. You don't have to wait for a fetal heartbeat. Would there be any harm prescribing it straight away? we don't think so. I mean, with all medicines in pregnancy, you want to be careful, because even though thousands of women have had progesterone and we don't think it increases any complications, you don't know about the long-term effects. So the main reason I say is to like try to stop us from masking ectopic pregnancies. But I think that's a discussion to have with your clinic, and based on your history as well, and when you've had pregnancy losses before, that might make an influence as to when to start it.
Okay. Question 7 is in relation to the polycystic ovary syndrome. Got 2 questions there.
I don't really know why. I think it's probably a metabolic thing, like the hormones are out of balance. You have slightly higher androgens. It's more linked with women who are overweight, and we know that overweight and obesity increases the miscarriage risk. We don't quite know why they have higher rates of miscarriage, and it's often not all that helpful when you look at higher rates of miscarriage. Like the rate of miscarriage is about 15% of all clinically recognized pregnancies. Now, I think the risk of miscarriage with polycystic ovary syndrome might only be 16 or 17%, so it's not massively higher. It's not like it's double the risk, but I don't think we really know why they have higher rates of miscarriage. And could it be useful in helping women prevent miscarriage? I don't quite know, because it won't help balance the excess androgens. It will make no difference to the androgens, but we don't. I think there's still a bit of the jigsaw that's missing. We know that progesterone is vital to pregnancy. We know that giving it might help some women, but we haven't yet joined the dots and been able to do a test to identify exactly who's going to benefit from it. So maybe I think this needs to be like the focus of some future research.
Okay. So got a couple of questions now in relation to the COVID vaccination.
No, that is a simple answer to that, and I even saw a review that was published earlier this week in Fertility and Sterility, which shows that the COVID vaccine didn't increase the risk of miscarriage at all, and I can't see any scientifically plausible reason why the vaccine would prevent you from producing progesterone in early pregnancy. So I think the answer is no to both of those.
Oh, that's good. So we've got a couple of questions now that are kind of personal experiences of miscarriage.
Yep. So I'll have to read this. Spotting for 4 or 5 days in the lead up to starting your period, worried it might be a hormonal issue or luteal phase problem. That tends to, sometimes women as they get into their later reproductive years might have a bit of spotting before their period, but the blood test looked okay, all unexplained. Okay, so got pregnant but had a miscarriage between 6 and 7 weeks. The progesterone level at 6 weeks was 12. So this again is difficult. Like doing progesterone levels when you've got a pregnancy is really in some ways unhelpful, because we don't know what the level should be, and perhaps a low level is actually not a reflection that there's a progesterone problem, but it's a sign that the pregnancy's not working anyway. And like I say, over half of pregnancy losses are due to the embryo not having the right amount of chromosomes, and that naturally you'll get that feedback and progesterone levels will fall. It doesn't necessarily mean checking the levels mean that there's an issue. And so you're wondering whether it's connected, and would you recommend supplementation? So I think I would definitely recommend, given the history of pregnancy loss, of progesterone supplementation if there was bleeding in a subsequent pregnancy. But I can't think of any other reason. I guess it's not quite clear from this either. Are these pregnancies that happen naturally, or are they after fertility treatment? Because that would affect whether to start progesterone, because after fertility treatment it's quite common to have progesterone for the reasons we talked about before. But I think if there's any early pregnancy bleeding, I'd recommend starting vaginal progesterone in this case.
Okay, thank you. And just another one here.
It's like a really sad story when you see so many pregnancy losses,
Yeah.
and that I think you can see why you'd start cyclogest quite early on from a positive test, and okay, the recurrent miscarriage say from 3 days post ovulation. So this is where you sort of get a little bit outside of the guidance, because none of the studies look at women that have had 6 previous miscarriages before. Even if there are women in the studies, like only a handful. So it's really hard to study this group. And if you take what we were thinking about before, that you got this biological gradient, maybe if you've had 6 miscarriages before, you're more likely to have a progesterone issue than if you've only had 1. And based on that, people think, well, perhaps maybe it's worth supplementing earlier on. We don't really know when the right time to do it is. You probably wouldn't get pregnant so if you took it like 3 days post ovulation versus a positive pregnancy test, I'm not quite sure what the difference would be from that. Only if you took it from ovulation, that might help improve your chances of pregnancy. But having said that, if you take it and then you don't get pregnant, you just delay your cycle and interfere what's happening naturally anyway. So I think there's pros and cons to both approaches, and there's not necessarily a right answer to that one.
Okay, thank you. That's all the written questions that are submitted, but I've got a couple of more questions, Matthew, that's been put in via the chat. Are you okay to answer a couple of them?
Yeah, so, absolutely. Yeah.
I'll just read it out to you. So the first one said, I'm a 41-year-old woman. I've had 3 failed embryo transfers. The last 2 were supplemented with progesterone. What more can be done? I'm about to have another round.
That's it's a difficult situation to be in, and unfortunately age increases the risk of pregnancy loss, and also increases the risk of fertility treatment not working. If there'd been no pregnancies at all, it might be worth having a look at what's at the cycle. But obviously you responded quite well if you've had 3 embryos from that cycle. And if you have pregnancy losses with those, it might be worth supplementing it with some injectable progesterone. But unfortunately, this is a really difficult one. Like doctors could like make up lots of reasons as to like why it's happened, and you can tell a good story, or it must be to do with your immune system and you're attacking the embryo. There's all kinds of stories that you can tell, but like the honest answer is no one knows. And in your circumstance, I don't know why you've had 3 failed cycles, and there aren't any good tests that's going to be able to answer that. And that's often like one of the things that's really difficult with fertility treatment, is that it raises more questions than answers. And you sort of really need to decide, look, is this something that I want to keep doing? And the more rolls of the dice that you have at it, the better chance you'll have. Unfortunately, that it's quite likely that at least 1, 2, maybe even all 3 of the failed cycles were due to the embryo not being right. And people have tried doing embryo testing to see if that improves the outcome. And while it might mean you get pregnant a little bit quicker, or it potentially reduces the risk of miscarriage, overall it doesn't improve your chances of having a baby, and it's a really expensive add-on. And I do question that for some clinics, is it more a way of being able to charge more for their treatment rather than actually having added benefit? So I think that you're in a difficult situation and probably need to have quite a frank discussion with your doctor at the clinic.
Thank you. Got another question here. Should you wean off progesterone after 16 weeks?
I think after 16 weeks, you could just stop it, because the amount you're absorbing from the pessaries will like dwindle in terms of what the placenta's producing. So stopping progesterone at 16 weeks, there's no harm in just stopping it straight off. I don't think it's going to cause any issues at all. That's why they say 16 weeks rather than earlier, because we know at that point there's definitely enough from the placenta. There's maybe a small group of women, and I personally think the evidence is less clear than for miscarriage, who are at risk of having a preterm birth, or may have previously had a preterm birth, or have a short cervix on an ultrasound scan because they've had a previous preterm birth that might benefit from taking it for longer. But for most women who've not had pregnancies or preterm birth before, it makes sense just to stop it at that point. It won't cause any problems.
Okay, and I've got a question here about risk. So is there a higher chance of miscarriage with premature ovarian reserve than progesterone could help with, or is it more likely to be chromosomal?
I think age is more important than ovarian reserve. We know that young women with a low ovarian reserve, so if you're 34, below 35 and got a low ovarian reserve, you won't have bad eggs. You'll still have good quality eggs, the same as another woman that age. But for women who are older, you probably have a low ovarian reserve and the quality won't be as good. So age is more important than ovarian reserve. AMH doesn't tell you anything about the quality of the eggs at all.
Yeah. Another question about research. So does the research suggest that progesterone isn't beneficial for people with recurrent implantation failure rather than recurrent miscarriage?
No, and that's because the study hasn't been done. Like, recurrent implantation failure is well, first of all, I don't like the term because it has the word failure in it. But having implantations that have not worked, there's different definitions for it. Like, does it have to be however many good quality embryos that are transferred? Do they need to have been biopsied before to know they're chromosomally normal? We don't quite know, and it's still most likely that that's perhaps different, a different kind of cause behind it rather than pregnancy loss, because pregnancy loss may, and there's even evidence that perhaps women who have recurrent miscarriages actually are more likely to implant an embryo, which is why they're more likely to have miscarriages. And perhaps it's a completely like other side of the coin if you're not implanting normal embryos. And we don't know if that's to do with progesterone or not, and there's plenty more research that needs doing there to explore things. And I don't think unless they're having difficulty absorbing the progesterone, it's as likely to be a progesterone issue.
Okay. I've got a question here about, I previously reacted to cyclogest with vaginal ulceration. So what would you recommend in future pregnancies if I have bleeding? Both my pregnancies, I have miscarried at around 6 weeks with bleeding from the positive test.
So I'm sorry that's happened, and cyclogest is quite unusual to get side effects from cyclogest, and because what the progesterone is mixed with is quite an inactive ingredient. So I've not actually heard of ulcers before, and it's worthwhile just trying to make sure it definitely is that's causing it. There's another alternative that can be used, something called utrogestan, which was used in both of the studies that we talked about this evening, and that comes in like a little capsule, rather which can still be used as a pessary, but it's different to it doesn't have the same waxy substance as cyclogest, and there's various arguments as to which one might be more effective that the different drug companies will tell you. But that's probably, like, the evidence is for vaginal micronized progesterone. Replacing that with injections, like I said before, you might find you get these swings in levels and it's less of a steady state. Unfortunately, like tablet progesterones or progestogens don't have the same evidence to back them up. So I think it'd be worth maybe thinking, like, is it definitely the cyclogest that's caused it? Trying a different preparations. Another one called Lutigest as well, I think, that is in the States, but I think you can also get it in the UK as an alternative to cyclogest. But the evidence is for vaginal progesterone. You can also use it rectally as well. Like, so if you don't want to use it vaginally because it's causing a problem, you can take it rectally and the absorption is exactly the same.
Okay, thank you. Another one here. I am 34 and I've had 5 miscarriages. My consultant has suggested a cervical cerclage as 4th miscarriage occurred in the 2nd trimester. All the others were within 12 weeks. Would progesterone and cervical cerclage combined heighten my chances of a live birth?
So this is one of the things that's really difficult when it comes to research is like, this is a very specific question, and like no one's ever going to be able to do a study that that answers that question for certain. And I think one thing that I didn't point out in my talk, and perhaps I should, is like the actual difference that progesterone can make. So 2/3 of, so I think you're looking about sort of in the 73% of women having placebo with early pregnancy bleeding would go on and have a baby. And if you take progesterone, that goes up to like 76%. So it's not very much of a difference between the two groups. So you need to treat a lot of women to have a benefit. What we don't know with this history is, we think that potentially, given that you had a second trimester miscarriage last time, is it to do with the cervix being short? And maybe there's some evidence that progesterone might help. I think if I was your doctor, I think I would be thinking about certainly cyclage. There probably is some benefit of using progesterone, and I would think that the benefit or potential benefit might outweigh any risk. But I think it's worth having that conversation with your doctor who knows you well.
Thank you. Just a couple of more questions now. So you touched on immune reaction. I have had 13 attempts with 3 loss and no live births. I tried lipid infusion for NK cells, prednisolone, and and then progesterone passers for day of transfer. The time I'm thinking just try natural, as with donor embryos, known success from batch. Should I still use progesterone pessaries post-transfer?
So I'm sorry about the experience you've had. It's a really long history there, and you've tried so many different things, and many of the, like the intralipid, the NK cells, the progesterone, the prednisolone and the clexane, they're all what are sometimes referred to as add-ons, and like none of them have any really good research to back them up. In fact, there's some evidence that some of those potentially can cause harm, like steroids, prednisolone can suppress your immune system. The same with like intralipid infusion. But progesterone is the one thing that has got some evidence to support it. And certainly, depending on how, if you haven't using donor embryos, I presume you'd be having a medicated cycle rather than doing it in trying to do a natural cycle. I think that taking some progesterone that's natural progesterone as well, we know that it's vaginal micronized progesterone is identical to what your body produces anyway. I would think that there may be some benefit to taking that. And if, for example, you have your embryo transfer and you're doing it all natural, but you've not released a very good egg that month, and your corpus luteum is not functioning quite so well, I think that you may benefit from having some progesterone supplementation. So I think out of all of those things, if you're going to ditch anything, ditch the others, but potentially progesterone is the one thing you may want to keep. I mean, there is also an argument for doing it totally naturally, and if you'd feel more comfortable doing that, I don't think you could necessarily say, look, you're reducing your chances. I think we don't fully know, but certainly I think that's the thing that's perhaps more likely to make a difference versus all the other things that you've tried.
Thank you. Just two more questions and that'll be us finished. So we had a miscarriage at 6 weeks. They did my progesterone day 21 test to see if I was ovulating the month I got pregnant, and it was 38 millimeters. Would that suggest I don't have a problem with progesterone?
It's quite difficult, that, because if you go back to the menstrual cycle chart and it shows like in the luteal phase, the second part of the cycle, it goes up like that. It depends on which day you get it, and maybe at 38 you've got it, and it's probably nanograms if it's 38. Often it says if it's over 20 it confirms ovulation. It maybe you got it on a good day, or it might have been 60 the following day. It even changes between morning and afternoon. So all that tells you is that month you definitely ovulated, but it doesn't give any other predictive value for your chances of pregnancy, whether it's going to do the same in another cycle. It doesn't tell you that much more than that. So I wouldn't focus too much on the actual result. I think the key thing is that, are you having regular periods? If you're having regular periods, it means that you'll be ovulating every month. and you don't need to check the progesterone levels.
Okay, and just a final question. So why is progesterone not offered as part of a natural IVF cycle? I have a short luteal phase and I wanted a natural IVF cycle with support of progesterone, but this was not allowed at the clinic.
I think it's, again, worth having a conversation with your doctor and your clinic as to why you want to do that. It's interesting to think that why did you have a natural cycle and then want to supplement it with something less natural? And the bit about the short luteal phase, that's still really difficult to actually define, and it's difficult. There's no test to look like what should be a normal like luteal phase, and no test to say, look, actually your progesterone level was low that cycle. I think it's worth having a conversation with your clinic, because it's a very unique circumstance to be going, look, I definitely want to have a natural cycle, but I'd like to take progesterone supplementation. And it kind of thinks, well, maybe perhaps to have a medicated cycle and take progesterone. So I think it's worth exploring like the reasoning behind why you want to do something, and your thoughts and fears. And like any good clinician should really listen to that and come to explain themselves as to why. I hate this kind of like not allowed at a clinic, because I think that modern medicine should be about having a grown-up discussion with patients, and taking every like individual person's point of view into account, and there's no like one size fits all. So I'd say, look, try and discuss it with your clinic, and or ask for a consultation to discuss it if they're not able to answer that over the phone.
Okay, well, thank you very much. That concludes all the questions for this evening. Thank you so much, Matthew, for coming along this evening and sharing that information.
I found it helpful.
Yes, absolutely. It's been a really great resource. It will be uploaded to our YouTube channel as well, so people can view in their own leisure, because I know that there was a couple of people certainly that weren't able to make it this evening. So thank you so very much for coming along and sharing your time and knowledge with us all. It's been really, really good.
That's all right. Thank you. Bye.
Thank you. Good night, everyone.